Welcome back to the Doctor is in television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here in beautiful Carmel, Monterey, Pacific Grove, Pebble Beach, California. I'm delighted you could join us. I am pleased, honored, delighted to welcome the real Dr. Morwood to the television studio, Dr. Betty Jo Morwood, psychiatrist in Burlington, Vermont, my wonderful sister.
Happy to be here. My
Betty,
wonderful David brother.
Well, Dr. Morwood,
Yes,
Betty Jo,
Dr.
my
Morwood.
sister, thanks very much for being here. I really enjoyed our last segment. You taught me a lot. I know you taught the public a lot, our viewing public. Today, during this first segment, I'd like to learn about bipolar disorder. If I can give a little introduction, it seemed to me years ago, maybe even when I was in medical school, we talked about something called manic depressive disorder.
Yes.
That's when someone would go from being super high, super energetic, and maybe go out and ride motorcycles and spend a lot of money, and then down like a roller coaster into a depressive episode and then back up to be high. I don't know if that's the same, or I don't know if that was accurate, but today we talk about bipolar disorder. I wonder if you could teach me and teach our viewers, really, what do we mean by bipolar disorder?
Well, let me go back to manic depressive illness. The change in words to bipolar is a way to try to make things more scientific and to widen the ability to diagnose and treat people, because some people who have bipolar don't have manic, recognizably manic. They're more hypomanic. That means they don't quite meet the criteria for the extreme manic behavior. So, but they still have that cycle, and so they are bipolar. And it's important to make the correct diagnosis because it has implications for treatment.
Well, so teach us, Dr. Morwood, Betty Jo, what are the criteria, or what's the behavior like? How does it manifest if a patient has bipolar disorder? What are they like?
Well, first of all, the depression, the depressive cycles. The depression is the same as a major depressive disorder. It looks the same symptoms, same difficulties with sleep, appetite, energy, concentration, as well as mood, withdrawal from society. It's exactly the same. That's why getting a history is so important. It used to be when I was a medical student, they would say, they taught me, it takes 7 years to diagnose someone with bipolar from the beginning, from the first symptom to an accurate diagnosis. And I was researching it a little bit last night to prepare for this talk, and the research said it takes 6 years. So you can see we've made some strides in diagnosis.
Well, so someone, does that mean if a person gets intermittently depressed, well, how do you if they don't get to the manic, or they don't get to the very super high behavior, how do you diagnose someone who just has a depressive episode or recurrent depressive episodes?
Well, that's the word, recurrent, cyclic. Some people, it's triggered by seasons, a seasonality you look for. And it's not the manic symptoms, but the hypomania can manifest as irritability. It's not the hyperactivity and impulsive actions that you'd see in a manic state, but impulsiveness. They might buy more than they could ever use, or buy more than they could pay for, that kind of impulsivity. But they're not manic. They won't forge a check. That's way loss of judgment. That's an extreme of somebody who is in a manic phase. They can't control their impulses. The hypomanic person still uses maybe poor judgment, but it's not the extreme. So a careful history. And sometimes it's not the person themselves that will tell you about those the manic times, because The hypomanic, especially, that's enjoyable because they have more energy. They don't think they need as much sleep. They can get more accomplished. They're enjoying life, so it's not a problem for them. So they wouldn't come to a psychiatrist and report it as a problem. Excuse me. It's when they're in the depressive cycle that they do come to ask for help.
Okay, so I have a question about when you said in the hypomanic stage,
Yes.
that's when they have a lot of energy.
Yes.
They can demonstrate irritability.
Irritability.
Well, if someone seems, in the common language, if someone sort of snaps and gets very angry or gets into fits of rage, now, is that perhaps a normal behavior that most of the population will experience one way or the other? Or those people who are diagnosed with bipolar disorder more often have those episodes where they'll snap and get very angry and might get into a rageful episode?
Someone who doesn't have bipolar illness, they may, snap or yell, but they won't have regrets afterwards. It maybe was an overreaction, but a real incident. Someone who is hypomanic will have that irritability, agitation, and there's, to the external viewer, there's nothing, it's just normal life annoyances. So it's an overreaction.
Okay, so perhaps I need to understand, either you misspoke or I didn't understand. So a person, let's say so-called normal person who snaps or gets into a rage, they will show regret afterward.
They have insight into why and what was stressing them out and why they acted the way they did. For somebody who is, say, hypomanic or starting, gearing up, going up the slope of a full-blown manic episode, they will justify it. They have no insight, no regret, no guilt. It's, there's a degree of grandiosity in someone who's hypomanic. And someone who has extreme mania, they can be delusional, grandiose. But hypo, it's just they just feel like they're so important that people shouldn't get ahead of them in line or something. It's that sense of being special.
Okay. Well, once again, going back to growing up and common terminology, etc. I had a musician friend who people said he was manic depressive. I don't know. But one time he rode his motorcycle into the hotel lobby.
Wow.
Where we had a gig and popped a wheelie on the carpet where there was a huge fountain and then drove out. Now, of course, that's not normally accepted behavior at all. But it sounds to me like, in fact, he was in a manic episode, right?
A manic episode, and often it's complicated by drug and alcohol abuse. Very commonly associated. So you have the lack of judgment as part of the illness, and then with the alcohol and drug abuse, it's worse. But yes, that is an example of a manic behavior.
Okay, manic episode. So a few minutes ago you said that the current, is it the DSM or the current diagnostic criteria, etc., indicates that you need to analyze a person for 6 years before you can make a diagnosis?
No, people would, sometimes it takes somebody up to 6 years to get an accurate diagnosis. But because the depressive part of a manic depressive illness is exactly the same. In the manic part, again, at times if somebody is full-blown, like your friend with the motorcycle in the hotel lobby, that's clear. But when it's not so clear, and they don't think anything's wrong, as I said, that's the grandiosity. So they won't report those manic phases as part of their problem that they come to a psychiatrist for.
Okay. Well, Betty Jo, Dr. Morwood, as I recall, there have been some very famous or innovators, scientists, researchers, investigators who seem to have so-called manic, not really manic episodes, but hyper energy, hyper curiosity, great interest, great curiosity that seems to go on maybe for years, and they will exist on very little sleep, and perhaps there have been some famous scientists, apparently, like Einstein, I don't know if it's true, who forgot to eat. Like his family would have to remind him that it's time to take a break and eat. Now, I don't think we would try to diagnose a very innovative, energetic researcher as being manic, or would we?
Especially if there's no crash, if there's no depressive, if they don't have to like pay for it with a deep, significant, almost sometimes suicidal depression. If somebody that's just their personality, they are very focused, overly, maybe overly focused, and they can maintain a direction, they can make progress. People who have been manic, they may think they are super creative and that grandiosity, and they're artists, but usually there's exceptions, but usually when they recover, they haven't been putting out great work. They're so over-inclusive, and the attention isn't there to bring anything, to sequence things to completion.
Okay, I'm not sure what that term means, over inclusive. What does that mean?
Well, when like I say, so how did you get here? Someone will say, well, I took the bus, but someone who is over-inclusive might say, well, first I had to go get my purse because, it's that bus, you can never tell how much it's going to charge you, and I lost the bus token on, and it's just all these
I see.
like little detours and colorings, and overly, it doesn't get to the point. That's, people have to be able to, they say, sequence to completion, that whether it's doing the laundry or carrying on a conversation, you have to follow in a logical sequence.
Okay, so in fact, or it's true, I believe, that a bipolar disorder manifests with episodes
Yes, with cycles.
cyclical
Yes.
behavior,
Yes.
like a roller coaster of high and low.
Yes.
So it used to be, I think, from my basic medical school knowledge, that a person once diagnosed with that would be treated with lithium. Is that
Lithium was the only effective treatment there was. Yes.
now? Do you call that a mood stabilizer?
A mood stabilizer. Yes.
So I think what you're trying to do is bring down the highs and bring up the lows.
Yes,
right?
exactly. If you think about a teeter-totter, a child's playground toy, you don't want to just give them an antidepressant, boost up, because that'll keep the whole system unstable. So you want to work on the fulcrum, or a balance beam. You want to, work on the middle to make that stable, and then, the person may need an antidepressant or a tranquilizer or something like that. But the primary goal is to first stabilize the mood.
So to stabilize the mood. Now, in addition to what we're talking about, psychiatric treatment, which some psychiatrists or medical people would say really what it is medical treatment. You need to properly medicate these people. What about the so-called talk therapy? What about psychotherapy? Can these people...
Yes.
Well, can these people gain insight into their own behavior, and can they, say, develop an awareness that I'm starting to get into a depressive episode, or I'm starting to get manic, and then treat it, or be on the lookout for it? Can these people have an awareness, or does psychotherapy help?
When somebody's in the middle of a manic episode, no. They lack insight, and they have no patience or tolerance for any feedback. Why would they listen to anybody else? But when they have stabilized, absolutely yes. People, just even basic behavioral changes, going to sleep on time, maintaining a routine, nutrition, cutting down whatever stress you can. The mindfulness, the meditative breathing, whatever will help people cut down on stress will cut down the mood swings.
Okay, so we talked briefly that lithium is still considered to be a mood stabilizer.
Absolutely.
It's effective.
Yes.
So what if someone comes to you with and they're in a depressive episode? How do you know whether they may be in this depressive episode temporarily and we can expect a high to come? Or how do you know that they just have maybe a long-term depression or recurrent depressive episodes? How do you diagnose that?
By the history. You have to get the history of what has come before, what has led them to this depression. If they've never, well, first of all, sometimes it's their age, that there's some certain ages where manic depressive illness will appear, and other times it's like if somebody is depressed for the first time after the death of a spouse, that's certainly not manic depressive illness. But if somebody has been is being like maybe a teenager, a late teen, and has the wild mood swings, that's a clue. That's a big strong clue.
Well, how long typically will these episodes last when we talk about the roller coaster? Is it every 6 months they sort of switch around? Is it every 2 weeks? Is it every month?
Well, everybody's different. Every 2 weeks would be an extremely unstable mood. Usually it's at least a few weeks, if not a couple, 3 months, that these will last. Again, with cocaine, with other drugs of abuse, that seems to really ramp up the system to drive this roller coaster to go faster.
So you said earlier that many people with bipolar disorder, they will complicate their behavior with drug use, addictive behavior.
Yes.
And it could be alcohol, marijuana, cocaine, methamphetamine.
Mm-hmm.
Is it predictable? It's just sort of any kind of mind-altering substance, or?
Well, I've heard more of the alcohol and the cocaine use. I don't know if that's because that's what was available. I've never researched if someone is particularly drawn towards a stimulant or a sedative kind of drug. But,
okay. Well, Betty Jo, we only have a minute or two left in this segment, but I have another question for you. So again, distinguishing between what we might call a normal person or normal mood swings as compared to someone who has a bipolar disorder or manic depressive episodes that needs help or is pathologic. Here on the Monterey Peninsula, oftentimes we will hear when it's foggy every day for a few weeks, I tend to feel kind of down or depressed. Or people say, I feel better when it's sunny. Or we talk about, back in Vermont, people get cabin fever.
Yes.
They get stir crazy because they don't have the fresh air and sunshine. They're sort of locked in. Now, most people, I think, would consider that so-called normal behavior or normal mood swings.
It is. And remember, I'm talking about a depression as an illness. It's not a mood. It's not a reaction to the environment or loss of a job. It's an illness. It's similar to epilepsy, that it just comes on. It's not connected. And it's a severe illness, as I say, that affects sleep and appetite and social connections, suicidal thoughts. It is an illness.
Okay. Dr. Morwood, one final question.
Yes.
So again, we talked about lithium. Now, bipolar disorder is treatable?
Oh, absolutely, yes.
With medicine and psychotherapy?
Yeah, behavioral techniques, as well as when they're not in a manic phase, insight-oriented as to what is stressing them. Also, maybe insight psychotherapy as to why they stop taking their medication, which is a very common problem.
Okay.
So,
Dr. Betty Jo Morwood, my wonderful sister, I very much appreciate you being on the program. Do you have time to stick around and do another segment?
I do, and it's my pleasure and honor to be here. Thank you, David.
Dr. Betty Jo Morwood,
Dr. Morwood.
psychiatrist in Burlington, Vermont. Thank you very much for being with us.
Thank you, David.
Once again, I'm Dr. David Morwood. I'm a board-certified plastic surgeon here in lovely, beautiful Carmel, California. This is the Doctor is in Television program. We're going to take a very brief pause for a very good cause. Thank you very much for being with us.
It's scary making the decision to have reconstructive surgery, but it's so worth what you get out of it.
I'm stress-free. I know I'm not going to get breast cancer.
Everything is back to normal, and it really did not take long to bounce back.
I have a sense of hope for other women that this surgery can help them to live normal lives.
This year, more than 200,000 women in this country will be diagnosed with breast cancer. For many of them, a mastectomy, or removal of the affected breast, will be recommended as part of the cancer treatment.
The idea of losing a breast for some women can be almost as difficult as being diagnosed with breast cancer. Modern breast reconstruction can help. The purpose of this presentation is to provide women with valuable information about the major issues in breast reconstruction.
We'll have an opportunity to speak with women who chose different methods of reconstruction. We'll talk to experts in the field of breast cancer, and we'll let you know your options for breast reconstruction.
I embraced the mastectomy and reconstruction procedure, and because of that, I had a terrific outcome, and it's changed my life in a positive way.
For the thousands of women who will be diagnosed with breast cancer this year, we understand this is most likely a troubling and frustrating time. We hope this presentation's been valuable to you and will help you make some very difficult decisions that you're facing.